Thank you, Devan, for the kind invitation to participate in this interesting session. So I've been asked to speak about whether all shallow anterior chambers need treatment. These are my financial disclosure and none relevant to this. So if you look at how we define angle closure in the clinically, it's mechanical occlusion of the filtering portion, which is the pigmented portion of the trabecular meshwork by the peripheral iris. But what do we see actually? We cannot see the pigmented trabecular meshwork on gonioscopy, and we consider that to be angle closure. And then how much should we not be able to see to be able to label it like that? If you can't see 180 degrees, you label it as angle closure. And then you further subdivide it into an angle closure suspect, where the only thing that you have is a gonioscopic narrowness. And then you have PSC, where you have either raised intraocular pressure or synechiae or patchy pigment, as doctor just showed you. Or you have angle closure glaucoma, where you have glaucomatous optic disc and visual field changes with or without synechiae or raised intraocular pressure. So that's a whole spectrum of angle closure disease that you have. So an occludable angle is essentially a primary angle closure suspect, which was 180 degrees. You cannot see the filtering portion of the trabecular meshwork. So why don't we treat everybody who is an angle closure suspect? Well, one answer for this is this. There's very little data on how many angle closure suspects actually progress to the next stage. The only data that you have from India is from the AIOS survey, and there are a couple of studies from Singapore, one of which Bhaskar did, and from China. So when you look at the AIOS survey, which looked at primary angle closure suspects untreated over 5 years, you found that 20% progressed. And 20% progressed to the next stage, which is they developed a synechiae or high IOP. Nobody developed disc or field changes. The data from Singapore and from China is even less progression. In fact, only about 7%, but that's partly because they use very stringent progression criteria. So what does this non-visibility of the pigmented trabecular meshwork mean on gonioscopy? What is its functional significance? So the thing is, it does predispose to angle closure, but if there was actual contact, you would expect the eye pressures to be high because that portion of the trabecular meshwork is not filtering. And actually, if you look at primary angle closure suspects and you compare them with primary angle closure and other people, you find that the pressures are not different. The pressure in primary angle closure suspects as a whole group is the same as it is in normal. You actually don't find any difference there. So the IOP is similar to the normal group. So what this means is a large proportion of people will appear to have apposition on gonioscopy. That does not mean that there is pathological damage which is causing a problem. So non-visibility of the pigmented trabecular meshwork on gonioscopy is not necessarily a clinical issue. The other reason why you don't treat everybody is, that's a map of Canada. And I put it there because as many people live in Canada are primary angle closure suspects in India. Approximately 30 million people. You can't go around doing 30 million YAG-PIs for a disease which does not really have a very high progression rate. And that's the reason why we are not so fussy about treating all angle closure suspects. The other risk is if you actually do a laser iridotomy for everybody, we have data from the Chennai glaucoma study, which shows that it increases the risk of cataract formation marginally. So if you decide to go and do YAG-PI for 30 million people out there, all cataract surgeons will be happy a few years down the line because many of those patients will progress. So what are the indications? Well, obviously, if you have an acute attack, you have to do it in the fellow eye as well as this eye. If you have a family history of glaucoma, definitely it's a strong indication for a YAG peripheral iridotomy. If you have somebody who requires frequent pupillary dilatations or coming from a very remote place, doesn't have access to care, or one-eyed patients, definitely go ahead and do the YAG-PI. If you have a patient who's very concerned, there's no harm done in doing a YAG-PI. If you have a patient who's very difficult to indent open, again, that's one more indication for doing a YAG-PI. So when you look at a laser iridotomy for PACS, not everyone needs it, but everybody who has it needs follow-up and monitoring and explanation that this is an issue that they have. It's better to give that in writing because that tells you that you've informed them of the risk and that they need to be followed up.